Imagine you are sitting in a clinic waiting room.
Right.
You've been dealing with severe vaginal discomfort for months, maybe even years, honestly.
Yeah, that's unfortunately very common.
Exactly. We are talking about painful intimacy, extreme dryness, or just the sense of laxity that is genuinely impacting your day-to-day quality of life.
It really takes a toll.
It does. So you've done the research, you've read the reviews, and you're finally ready to book one of those cutting-edge vaginal laser or radiofrequency treatments.
You're ready for a solution.
Right, you're at the reception desk, credit card in hand, feeling this sense of hope, and then the receptionist stops you cold and asks for your latest cervical screening results.
Oh, yeah, that happens a lot.
They tell you it needs to be completely clear before you can even schedule a consultation.
It stops a lot of patients right in their tracks, you know?
I bet. It
Uh,
feels like hitting a massive wall of medical bureaucracy right when you're at your most vulnerable.
People often expect these procedures to operate like a standard cosmetic, facial, or just a surface-level dermatology appointment.
Like you just sign a waiver and walk in.
Right, exactly. But the reality of the medical protocols surrounding these specific energy devices is, well, it's far more complex.
Which is exactly why we are here. Welcome to this deep dive into the fascinating intersection of everyday preventive care and high-tech medical treatments.
It's a really interesting space.
We've gathered a huge stack of medical guidelines, clinic protocols, clinical studies, and FDA safety communications. And our mission today is to answer one highly specific, absolutely critical question.
And that is,
Should your cervical screening be up to date before you undergo vaginal laser or radiofrequency treatments?
when you actually peel back the layers and look at the underlying science, you realize this prerequisite is not just arbitrary red tape.
It's not just clinics being difficult.
No, not at all. The guidelines are structured around some very profound biological realities.
Well, before we get into those rules, I think we need to understand the biological reality of the treatment itself. Let's break down these energy treatments.
Sure, because vaginal laser sounds incredibly sci-fi.
It really does. But the sources detail some very specific, distinct technologies here. We are looking at fractional CO2 lasers, like the Mona Lisa Touch,
Right.
and then we have erbium YE lasers, like Photona Smooth, and then a completely different category, which is radio frequency or RF devices like VVAVE and Ultrafem 360.
Right, so you have these distinct technologies, but the common thread across all of them is their primary medical target.
Which is treating genitourinary syndrome menopause, or GSM.
Exactly. See, when estrogen levels drop during menopause, the entire landscape of the vaginal tissue changes.
It really just transforms, doesn't it?
It does. The mucosal lining thins out, the tissue loses its natural elasticity, its moisture, and just its physical, robust texture.
The cellular turnover slows down drastically, right?
Yeah, precisely. So these devices are essentially stepping in to mimic the rejuvenating effects of estrogen, but mechanically.
Okay, so like the fractional CO2 lasers, they use light energy to create this microablative damage.
Right, controlled damage.
It sounds a bit like aerating a compacted lawn.
Oh, that's a great analogy, actually.
Right, like you aren't just pouring water on dry dirt and hoping for the best. You're using a machine to punch thousands of tiny microscopic holes into the soil.
Exactly. And that minor controlled trauma forces the roots to breathe, absorb nutrients, and grow back significantly stronger.
So the vaginal mucosa responds to those microinjuries the exact same way.
Yes, through the exact same mechanism. The thermal injury triggers the body's innate wound healing cascade.
So the body's repair system wakes up.
Right. Fibroblasts, which are the cells responsible for the structural framework, suddenly wake up, and this stimulates neocollagenesis.
Which is just a fancy word for making new collagen, right?
Exactly, the mass production of new, healthy collagen fibers. And it also promotes angiogenesis, meaning the formation of new blood vessels.
Wow, okay. So you are driving fresh blood flow, oxygen, and nutrients into an area that has been essentially starved of them.
You've got it. The tissue plumps up, elasticity returns, and natural lubrication improves.
Okay, so that's the lasers. What about the radiofrequency devices?
They achieve a similar end goal, but through a different pathway. Instead of ablating the surface tissue, devices like VVAVE use radio waves.
Right, to create volumetric heating deeper in the submucosal layers.
Exactly, while simultaneously cooling the delicate surface. But the result is basically the same.
Thermal heat triggers the fibroblasts to remodel the collagen matrix.
Yes, which brings us directly to the clinical protocols.
Okay, let's unpack this. Because if the goal is just to stimulate collagen in the vaginal walls, why are clinics so obsessed with the status of my cervix?
Well, if we understand that these devices are triggering a massive cellular response.
Right, driving blood flow and forcing tissue regeneration?
Yeah. Exactly. Then the strict screening timelines enforced by clinics begin to take on a very different context.
I mean, the timelines are undeniably rigid. Like, if you look at the protocols from the Hot Work Clinic in our source,
Yeah, they are very strict.
they explicitly mandate that any laser treatment must be preceded by a full gynecological exam, and the pap smear cannot be older than 3 months.
Just 3 months.
3 months is an incredibly tight window, especially when standard preventative guidelines often suggest a screening every 3 to 5 years, depending on your age.
Yeah, Hot Work is definitely demonstrating a highly conservative safety protocol there.
But even the more flexible clinics hold a firm line, don't they?
They do. PRFCT, which uses CO2 lasers, and VIV clinics both state that a patient must have a clear, documented pap smear within the last 12 months.
And even the academic research reflects this hardline approach.
Oh, absolutely. Look at the 2017 Purali clinical study.
Right, the one that looks specifically at the efficacy of fractional CO2 lasers for postmenopausal women.
Yeah, they used incredibly strict inclusion criteria just to get into the trial. Out of the 77 women selected, every single one had to provide a negative pap smear.
And it couldn't be older than a year, right?
Correct. Or a negative high-risk HPV test not older than 5 years. They were actively weeding out anyone without a verified healthy cervix.
Okay, so why is this such a universal rule?
Well, the setting of these procedures plays a massive role in why these baseline rules exist. Historically, highly invasive procedures were confined to specialized OB/GYN offices.
Or hospitals where they already have your whole patient history on file.
Exactly. But today, these energy treatments are increasingly performed in outpatient settings, from specialized clinics to broader medical spas.
So the person holding the laser might not be your primary care doctor.
Right. Because of this wider commercial availability, generalizing these treatments without a universal, strict baseline rule is incredibly dangerous.
So the safety net.
It's the absolute first line of defense for patient safety in a decentralized medical landscape.
Okay, I hear that, but I have to challenge the logic of that timeline a bit.
Okay, go ahead.
A pap smear, or an HPV swab, is testing the cells of the cervix, right, which is sitting all the way at the very top, essentially at the apex of the vaginal vault.
That's anatomically correct, yes.
But these laser probes and radiofrequency wands, they're actively treating the walls of the vaginal canal itself. They are anatomically distinct areas.
They are.
So are clinics just demanding a 3-month or 12-month cervical swab just to cover themselves legally? Or is there an actual physical biological danger in applying energy to the vaginal walls if the cervix hasn't been cleared?
Oh, there is a profound biological danger. To understand the gravity of it, we have to look at the cellular level.
Okay. What happens when intense thermal energy meets abnormal cells?
Well, the contraindications, the absolute medical warnings against proceeding, are unambiguous across every single source we reviewed.
Yeah, the guidelines from Columbia Shores and Christy Cobb, MD, detailing the protocols for the monolith touch, they list these absolute hard stops.
Right. You cannot undergo the procedure if you have an abnormal pap smear, an active high-risk HPV infection, or any unevaluated cervical lesions.
And the clinical paper covering non-surgical vulvovaginal rejuvenation emphasizes this exact point, too.
It does. Any abnormal smear results entirely preclude a patient from receiving energy treatments.
Until they undergo an immediate, comprehensive medical evaluation, usually via a colposcopy.
Exactly.
So what is the actual mechanism of danger here? Let's say a patient skips the screening.
Okay.
They have dormant or active precancerous cells on their cervix, and a practitioner inserts a fractional CO2 laser to treat their vaginal dryness. What happens at the cellular level?
Well, think about the primary function of the laser we discussed earlier.
It delivers ablative or thermal energy to stimulate a massive increase in local blood flow.
Right. Angiogenesis and rapid cellular turnover. Now, imagine applying that stimulating environment to an area harboring precancerous cells or tissue infected with a high-risk strain of HPV.
You're essentially throwing gasoline on a fire.
Exactly. Instead of just stimulating healthy collagen, you are introducing microtrauma and a rush of blood supply to a tumor microenvironment.
Or an area where the cells are already dividing abnormally.
Yes, you are altering the local immune response.
Because HPV often sits dormant in the basal layer of the epithelium, right?
Right. So the microinjuries from an ablative laser, combined with that inflammatory healing cascade, could theoretically disrupt the local immune surveillance.
Or accelerate the dysplasia.
Exactly. You are asking the body to focus its energy on remodeling the superficial tissue while a potential malignancy is brewing right next door.
Applying this kind of uncontrolled energy to an undiagnosed lesion is just a catastrophic risk.
It really is. And the danger of misdiagnosis is just as alarming.
Yeah, the FDA issued a major safety communication in 2018 regarding the marketing of energy-based devices for vaginal rejuvenation.
They warned about adverse events like severe burns, scarring, and chronic pain resulting from these treatments.
And while the clinics and manufacturers fiercely defend the safety of their devices, they universally agree on one thing.
That safety is entirely dependent on perfect patient selection.
And the issue of perfect patient selection comes down to symptom overlap, doesn't it?
It does. If you look at the early warning signs of cervical cancer, the clinical presentation is remarkably similar to benign conditions.
The sources highlight abnormal vaginal bleeding, postcoital bleeding, which is bleeding after intimacy, and generalized pelvic pain.
Right, those are key indicators of cervical pathology.
Well, wait, postcoital bleeding and pelvic pain are the exact primary symptoms of genitourinary syndrome of menopause.
Exactly. The tissue thins out, it loses lubrication, and the friction of intimacy causes it to tear and bleed.
Wow. Okay, so this is where the lack of screening becomes genuinely medically negligent?
Yes. Imagine a postmenopausal woman goes into a wellness clinic complaining of painful intimacy and light spotting.
And without a recent screening on file, a practitioner might easily look at that friable, pale vaginal tissue and confidently diagnose simple atrophy.
And then they prescribe a multi-session laser treatment to thicken the mucosa and stop the bleeding.
Meanwhile, the bleeding isn't coming from thin vaginal walls at all.
No. It could be coming from a friable cervical lesion shedding malignant cells.
So the practitioner uses the laser to treat a symptom of cervical cancer, assuming it's just menopause.
Which actively delays the life-saving oncological intervention the patient actually needs.
And the laser might even temporarily improve the surrounding tissue, right?
It might, which then masks the severity of the underlying cancer until it advances to a much more dangerous stage.
That's terrifying.
If we connect this to the bigger picture, you can never ethically treat a symptom without definitively ruling out the most dangerous underlying diseases first.
That completely reframes the entire waiting room scenario from the start of our deep dive.
Doesn't it?
It's not an administrative hoop. It's a vital diagnostic firewall to ensure a fatal disease isn't being masked by a functional cosmetic fix.
The logic is entirely bulletproof. You absolutely must get the swab.
But as we transition into the realities of patient care, this creates an incredibly frustrating situation.
It really does.
The guidelines from the British Society for Sexual Medicine, the BSSM, highlight a massive real-world complication that arises from this very requirement.
It creates a clinical catch-22 for the most severe cases.
Let's paint the picture of this speculum paradox based on the BSSM findings. Women dealing with untreated, severe GSM suffer from extreme tissue fragility.
Right. The vaginal epithelium becomes incredibly pale and friable. It essentially loses its structural integrity.
Because the tissue is starved of estrogen, right? The natural folds, the rugae, they just disappear.
Exactly. The canal narrows and shortens, and the natural elasticity just vanishes.
These women are in constant radiating pain. They are the ideal candidates who desperately need the laser or RF treatment to restore their tissue and eliminate the pain.
But to get the laser treatment, they have to prove their cervix is healthy.
Right. And that requires a doctor to insert a rigid metal or plastic speculum, open the vaginal canal to visualize the cervix, and physically swab it.
And for a woman suffering from severe advanced GSM, the mere insertion of a standard speculum isn't just uncomfortable.
It's agonizing.
It truly is. The rigid instrument forces open tissue that has lost its ability to stretch,
Causing micro tears, bleeding, and intense pain.
The sources are very blunt about the psychological and physical toll of this.
Because of this agonizing pain, a significant number of postmenopausal women actively avoid their cervical screenings entirely.
They fall completely off the preventative healthcare map.
So the patient is stuck in this nightmare loop. You desperately need the laser to fix the excruciating vaginal pain.
But you must endure the excruciating pain of the speculum screening to be allowed to access the laser.
Here's where it gets really interesting, but also incredibly frustrating for the patient. How do you break out of a cycle where the cure is locked behind a test you physically can't endure?
Well, healthcare providers are deeply aware of this barrier, and the BSSM guidelines provide a specific phased medical workaround for this exact scenario.
It requires some time and patience from the patient.
Yes, but it safely breaks the cycle without compromising those crucial oncological safety protocols.
So if a patient physically cannot endure the speculum insertion, what do they do?
The BSSM advises prescribing a short, targeted course of local vaginal estrogen.
And it is crucial to distinguish this from systemic hormone replacement therapy, right?
Very crucial. This is a localized cream, tablet, or pessary inserted directly into the vaginal canal.
Typically used for a few months prior to the attempted screening.
Exactly. This localized estrogen acts as a targeted rescue mission for the tissue.
It provides just enough hormone to temporarily thicken the epithelium and stimulate some basic revascularization.
Right. It restores a baseline level of moisture and structural resilience.
And then you combine that with a clinician using specialized pediatric speculums and copious amounts of targeted lubrication.
And you change the entire physical landscape of the exam.
So by utilizing the localized estrogen for a few months, the tissue becomes robust enough to handle the mechanical stress of the speculum.
The screening actually becomes tolerable. The patient receives their required swab, the sample goes to the lab, and they get the all clear.
It's essentially prepping the canvas. Once you navigate that temporary estrogen protocol and secure the healthy screening result, you finally unlock the door to the long-term laser or radiofrequency therapies.
Right. It creates a delay in accessing the primary treatment, which is undeniably frustrating for someone in chronic pain.
But it bridges the gap safely.
It satisfies the absolute necessity of the cancer screening while keeping the pathway open to the advanced energy treatments.
It requires a strategic roadmap between the patient and the provider, but it ultimately works.
It does.
So, returning to the core mission of our deep dive into these medical protocols,
Okay.
should your cervical screening absolutely be up to date before undergoing any form of vaginal laser or radiofrequency treatment?
The clinical consensus, the safety guidelines, and the biological realities all point to an unequivocal yes.
It is the ultimate safety check. It ensures that ablative heat or thermal energy is never applied to active viral infections or precancerous cells.
Exactly. It guarantees that symptoms of something as serious as an undiagnosed cervical malignancy aren't accidentally masked as simple menopausal laxity.
And it ensures that when you finally sit down for that energy treatment, the device is doing exactly what it was engineered to do.
Healing the tissue, regenerating the collagen, and restoring your quality of life without hidden risks.
But before we wrap, there is a very recent update from the HRSA, the Health Resources and Services Administration, found in our sources.
Oh, yes. This introduces a fascinating variable to everything we just discussed.
The new HRSA guidelines state that women aged 30 to 65 who are at average risk for cervical cancer have a new option.
They can self-collect their own samples for HPV testing.
Instead of enduring a clinical speculum exam, a patient can use a simple, self-administered vaginal swab to collect the necessary cells.
Either in the clinic's bathroom or entirely at home.
Consider the implications of this for the speculum paradox we just talked about.
It's huge. For women suffering from severe vaginal atrophy, where the pain of a rigid speculum has kept them from getting screened, the simple swab completely bypasses the mechanical trauma of the exam.
Could this painless, self-collected HPV swab be the key that finally eliminates the catch-22 entirely?
It really has the potential to instantly unlock access to life-changing laser and radiofrequency treatments for thousands of women.
Completely removing the agonizing hurdle of the speculum. It's a massive, exciting shift in healthcare access.
It really is, and it leaves us wondering just how quickly clinics will adapt their protocols to embrace this new era of self-screening.